Okay. Fine. So I think we are live now. Let me get started with this presentation. Good evening, everyone. Thank you for joining us today to discuss an important topic on towards patient-centered access to quality cancer care and the challenges faced there. We have today a stellar panel that we will be talking to. Unfortunately, Dr. Gayatri Palat will not be able to join, but the rest of the panel is here. Let me quickly introduce, So a quick introduction on PatientsEngage. As some of you know, we are an online platform which seeks to inform, engage, and empower patients and caregivers. And we strongly believe that the better patients are informed, the better decisions they are able to make in terms of their own health choices as well as quality of life choices. And they feel better equipped to handle discussions with healthcare professionals as well. Over the last few years, we've done a lot of webinars and we've got a lot of content on the website as well, putting patients and survivors at the center of our discussions, talking about various aspects of body image, psychosocial effects of stoma bags, side effects of treatment, fear, stigma, talking about silence on gynecological cancers, relationship issues of how to talk to your children about cancer and how children felt about when their parents had cancer, spouse relationships, and we've also talked a lot about prevention, about how to stop tobacco, childhood cancer, navigating care, as well as, kind of issues of quality of life like lower limb lymphedema, which, hardly anybody talks about. And a whole bunch of stuff which you can find on our YouTube channel. All of these webinars are up there. Just a guideline to the attendees, the information being discussed here does not replace a medical consultation. So if you have specific issues, please do reach out to your treating physician. This session is being recorded, and if you're logged into Zoom, you can post your questions on the Q&A. If you're on Facebook or YouTube, you can post them on the live feed and we'll pick it up. And at any point of time, you can always write to us at editor@patientsengage.com, and you can follow us on our social media channels. Our website is patientsengage.com. The partner for this session for us is EHA Consortium, which is Equitable Healthcare Access Consortium. It's a nonprofit organization conceived by world-renowned healthcare and management professionals from LV Prasad Institute, Indian School of Business, Fernandez Hospitals, Tata Memorial, Mumbai, BHS Rajasthan, IM, Udaipur, Arvind Eye Hospital, Vikram Hospital, Bangalore, People Tree Hospitals, Earth, SSI, SM, Dhan Foundation, etc. EHAC aims to provide equitable healthcare access to all via a growing network of individuals, organizations by promoting a culture of collaboration, cross-learning, education, and healthcare transformation. So please visit ehaconsortium.org, and you can check out the team as well. I am a member of EHAC, and Dr. Pramesh is also part of EHAC. Our panelists today, we have with us Urvi Sabnis, who's a patient advocate and breast cancer survivor for over 5 years. And she works closely with patients and their families. I love her attitude that she says, cancer is just one chapter in her life and it's not the last, right? And she has been one of the key pillars of the cancer content that PatientsEngage has put out. Dr. C.S. Pramesh, Director of Tata Memorial Hospital, Convener of National Cancer Grid. He also serves on the UICC Board of Directors. He's the Professor and Head of Thoracic Surgery at Tata Memorial Center, Mumbai. He will talk a little bit more about National Cancer Grid, which is a network of 244 cancer centers. But do check out their website as well. He is highly committed to efforts towards reducing inequities in cancer care and making cancer treatment accessible to all geographic regions and strata of society, and is a visiting professor at the Division of Cancer Studies, King's College, London, and the Institute of Cancer Policy, King's Health Partners, London. We also have with us Dr. Mathew, who's a consultant medical oncologist and hematologist at the Ernakulam Medical Center and MOSC Medical College, Kolancheri in Kerala, India. He's an American board certified physician who is actively pursuing research into issues pertaining to the quality of life of patients living with cancer. And for those of you, I'm Aparna Mittal. I'm the founder of PatientsEngage, and I'm the moderator for the session. Let me quickly get into the topic, and I think I'll stop sharing. So the primary goal and benefit of patient-centered care is to improve individual health outcomes and not just population health outcomes, although population outcomes also improve alongside it. So the objective of this webinar is to provoke constructive discussions and conversations and identify areas where we can all collaborate and work together. I'd like to start with stating a few examples of based on the stories we listen to, the narratives of patients, and then we'll get started. I was not told what to expect in terms of stoma bag usage and not told how to select one, how to use one, and I had to figure that out. My brother's brain cancer caused seizures, but the hospital staff told the wife that he must have had seizures before the marriage itself. And as a result, the marriage broke down. My mother's pain is so high and the doctor is not telling me how I can address that pain for my mother. My husband was suicidal after head and neck cancer surgery because he could not deal with his changed appearance, but we didn't know what to do. I was the ideal ovarian cancer patient, diagnosed early, stage 1 actually, but I now live with lower limb lymphedema and struggle with 3 hours of dealing with it every day. So, here are just a few examples, and I think we will get into more, but just to identify that there are issues that people struggle with, and cancer is not, as most people think, that, you get treated and it's over. People live with psychological issues, they live with sometimes side effects and consequences of the treatment and consequences of cancer itself. So we just wanted to frame that, and I'd like to get started with you, Dr. Pramesh. If you can first let people know what is National Cancer Grid and what it aims to achieve. And I know it's made significant progress, but if you can just kind of recap that very quickly.
Thank you, Aparna, and pleasure to be part of this panel. Again, a lot of what you spoke about in the last few minutes strikes a chord because all of us are in it for making patients' lives better. And somewhere along the way, I think we've kind of had this tension between how do we look at it from a patient's point of view, how do we look at it from a health system's point of view, and how do we look at it from an overall ecosystem of cancer care. And I think we are still struggling. And in the best of situations, in the most developed of economies, we do grapple with this dilemma about what we should prioritize and through what lens do we approach this problem. So I'll cut to the chase and come to the evolution of the National Cancer Grid. And the whole thing started almost about 10 years to the date, when we had done a study along with an NGO of 75,000 patients who visited the Tata Memorial Hospital over a 6-month period, where we geotagged where they hailed from, where their original residence was located. And unsurprisingly, what we found was that just 13% of our patients came from the city of Mumbai. 87% of patients came from outside Mumbai. Over 60% of patients came outside the state of Maharashtra. And a substantial part of them traveled over 2,000 kilometers to access care at the Tata Memorial Hospital. So just to give you an idea of scale, we see 45,000 new patients with cancer annually at Tata Memorial. And we are amongst the largest centers in the world as far as patient flow is concerned. And just to give you again a better example, a better understanding of how this works, we are sister institutions with the MD Anderson Cancer Center, and we are remarkably similar in the number of patients that we see. We see 45,000, the MD Anderson sees 42,000. And while the MD Anderson has 1,700 physicians and researchers on their faculty, we have 188. So just to give you an idea of the scale of the problem that we're dealing with. The second aspect that we needed to think about was the increasing burden of cancer in India. And while the age-adjusted standardized rates of cancer has more or less remained as a straight line, we've not had an increase when you look at it standardized for age. The fact that a large part of the overall population of India is increasing, the fact that the life expectancy in India is increasing, and there is growing urbanization, the absolute numbers of cancer in the country are growing rapidly. And we're expecting something like a 70% increase in the absolute numbers of patients with cancer in 2 decades. Given the fact that there was an Ernst & Young report approximately 6 or 7 years back, which looked at what was the gap in the facilities that we had as compared to what was ideal. The ideal was a very far away. And even given the fact that we are an LMIC and we needed to be frugal with our resources, we were somewhere between 40 to 45% of what we needed to have as far as the total number of cancer centers, the number of cancer beds, the specialist oncologists, as well as the number of other surrogates like the number of linear accelerators in the country were concerned. So we needed to think of something pretty disruptive, something out of the box when it came to tackling a problem like this. We couldn't expect that the natural growth or the normal way healthcare industry grows would be enough to cater to these problems. So we came up with this idea of, rather than come up with newer centers, what can we do to kind of democratize cancer care in the country? And to me, even today, while we might talk of cancer moonshots, I think President Biden had a cancer moonshot resurrection a couple of days back in the US. But to me, more than moonshots, what we require is how can we ensure that what we know today is available to the vast majority of patients? And there is this inherent tension of what is important for an individual patient as compared to what is important for the entire system. And we took a step back and thought that what the single biggest impact we could have is to have uniform standards of care. To me, if we are able to achieve this goal of having uniform standards of care in India, we could do away with the CAR T cells, we could do away with the fancy new drugs, the robotic surgeries, the proton therapy, and have much bigger impact on survival than what we have today. And that is the reason we embarked on this fairly ambitious program called the National Cancer Grid. When we pitched this to the government of India 10 years back, it was early 2012 when we did this. Surprisingly, we found a lot of support from the government, and they actually took a leap of faith in funding us for 7 years with a pretty substantial grant of 72 crore rupees. And at that time, when nothing was proven, I think this is probably the biggest decision that they've taken, which enabled us to do what we were able to do over the last 10 years. So I could talk about what we've achieved over the National Cancer Grid for the next 3.5 hours and still run short of time. So I'll not go into that. But I think much of this will come into the discussion as we speak through this session. But the fundamental pillars on which the Cancer Grid is founded upon is, first, to have uniform standards of care across the country. Second, to create adequate human resource to upskill individuals working in the field of cancer to try and see how we could make do with the available resources and make it more democratic. And finally, use this platform to be a ready platform for research in cancer, which is specific and unique to India. The reason I emphasize on the last point is that while there might have been a lot of progress made in cancer research over the last couple of decades, much of it is not applicable to India because they are so expensive that it is out of reach, or pharmaceutical companies don't think it worth their while to bring these new advances to India because the market is not big enough. And we want to look at it completely differently, look at how we can use health economics, health technology assessment to ensure that the meager amount that we spend on public healthcare expenditure in India is used well. So I'll stop with that, and I'm fairly sure that there'll be questions coming up later which will address some of the areas that the Cancer Grid has worked upon.
Right. So thank you, Dr. Pramesh. I think that captures very well the what NCG is about and what you're trying to achieve. From a patient perspective, what can a patient expect if they go to any of the member hospitals of National Cancer Grid?
That's a really important question, and it comes to the core of what the NCG was actually founded upon, which was to ensure that regardless of whether a patient was in Naharlagun in Arunachal Pradesh, Sopore in Jammu and Kashmir, Tirunelveli in Tamil Nadu, or Raipur in Chhattisgarh, or Ahmedabad in Gujarat, they get exactly the same care that is available. I don't even want to claim that over 10 years we've been able to ensure this. This is still work in progress. But what each of the NCG centers endorse and sign up to when they become members of the NCG is that they will adhere to the evidence-based guidelines which come out of the National Cancer Grid. Now, all of us who are in India realize that having guidelines is one thing, and ensuring adherence to these guidelines is entirely a different issue. But we were fairly liberal in the way we allowed membership to the NCG. We don't have restrictive criteria to become members because something like this has never been attempted in India, and we didn't want artificial barriers to quality when it comes to becoming or aspiring to be better. And therefore, anybody who wants to become a member of the NCG can become a member of the NCG. Now, the critics might say that this is allowing any level of quality without ensuring that the same levels of care are considered. And this is not something that we've not thought of or deliberated before. So we could take the tough stance and say, unless you adhere to guidelines and ensure or demonstrate that you are adhering to the guidelines, you will not become a member. Or we could take the other way out and say you can become a member and then try to aspire to adhere to these guidelines. We took the latter option primarily because, again, as I said before, this has never been attempted in India before. And if we were to have these artificial barriers in place, we would not have been able to achieve what we've been able to do over the last 10 years. Having said that, what was extremely fortuitous and completely unanticipated was the fact that the largest insurance scheme in the world, which is the ABPMJ, signed up to linking reimbursement under the scheme to adherence to the NCG guidelines. So when we started with the effort to create uniform consensus guidelines, we never thought that this would happen. This was a shot in the dark. Right. But fortunately, what ABPMJ saw was value in looking at quality when it came to reimbursement. And they took cancer as a pilot. And to this date, no other specialty in medicine is linked to adherence to quality of guidelines as far as the ABPMJ is concerned. And they're looking at this as a pilot to see how things work. They've integrated this into their IT software. And today, you will not get reimbursement under the ABPMJ unless you adhere to the unless you adhere to the NCG guidelines, or in the exceptional circumstances where your clinical situation doesn't fit into the NCG guidelines, there is an expert oncologist who certifies that this is a reasonable way of treating. So I think we've reached some distance from where we started, but this is still work in progress, and I'm hopeful that in the next year or two, we will have more progress on this front.
Great, thank you. Thank you. Urvi, coming to you, from the perspective of patients, and you talk to so many patients all the time, what does quality care mean? What do patients want? and I'm cancer care.
Yeah, thanks Aparna for having me. And based on my interactions with the patients and caregivers, I have 3 points to make to your question. First and foremost is information. Like most of the patients are not fully aware what they are getting into, and at times they are so stressed that they are not even, they don't know whom to ask or what to ask. So if in our healthcare system we have a dedicated team which can give information proactively to the patient about the nitty-gritties and nuances of the treatment and beyond, and we can classify into 3 categories, like financial, physical, and mental, as you said, how to handle the stoma bags or financial aid, or right from there to a small tip like which type of comfortable clothing to wear while going for an examination or something. And I feel that this team should be equipped in such a way that they can talk to or guide the patients from all the stratas, like socioeconomic stratas and literacy levels. So
Right.
as we have FAQs in one language, we should have it in multiple vernacular languages. And I feel even infographic videos or pictures may also help. As we have a protocol about the treatment, we should have a protocol of meeting this team right after the discussion with the doctor.
Right.
I feel that this may definitely empower the patient for taking the right decisions, and they should be given all the choices. Like at times, I feel that not everyone gets to know about the reconstruction, or there are plenty of other things which will take time if we go into that. Another thing is communication. We keep talking about mindset, that the positive mindset helps in better recovery and all. But I have seen that patients are not heard properly, because doctors are really, really busy. And at times, medical fraternity feels that the question is too small or inconsequential. But for a patient, it is not so. So they need to be heard. And when we talk about communication, it is not only between doctor and the patient. It's among the caregivers, support staff, support group. So if everyone is trained to talk to the patient, it will definitely help. These are communication and information are the two measures to be taken. My third point is compassion. Like these two measures are to be engulfed by compassion. Patients should not be pitied upon, but definitely dealt with a lot of compassion. I mean empathy and not sympathy.
Right.
Yeah, that's it.
Okay. Thanks. Thanks, Urvi. Dr. Raju, from your perspective, when you've been studying this also a little bit, what are the barriers to equitable quality care in, based on your experience?
Thank you, Aparna. I'll add on to what Dr. Pramesh and Urvi has been talking the last few minutes. Equitable, as I define, is something where patient A gets the same care as patient B from whichever part of the country or the world they come from. And
Right.
Here's where I think the focus of today's discussion is also important.
Correct.
You can have equitable poor care. You can have equitable good quality care. We should focus on getting equitable high quality, good quality care.
Yeah.
The key barrier, the big elephant in the room that often gets less attention rather than treatments and the side effects is the financial side effect of treatment and the care. The financial adverse problems, the imbalance. A poor person, can he get the same high quality care as somebody who's affluent? But
Right.
Today I want to bring up the other part of the coin too. Even assuming finance is not a problem, even for the wealthy, even for the rich and the affluent, quality care is still out of the reach, in my opinion. Money doesn't buy you quality care. I think the barriers to equitable cancer care, while we talk about finance, the cost of care, I think we should also address the fact that quality is also sort of sometimes independent of how much you pay and how much is your
Correct.
ability to pay. And that's where I think the two things that both Dr. Pramesh and Ms. Urvi mentioned, which is guidelines and which is information, that is key. There is always going to be a power differential, an information differential. Even if you're wealthy, you may not have access to all the information that you need. And that's where we need to bridge the doctor with the patient advocate. That's where patients engage, EHA, EHCP, all this comes into play.
Right. Thank you. Thank you. I think one of the challenges we've come across, and I was looking even at the ABPMJ data, and Dr. Pramesh, you probably are aware as well, that when they released the results of last year's data, even under the scheme, there is a lot of treatment abandonment. So from what the packages were underutilized by significant percentage. And I think most people end up doing surgery, but don't do the rest of the treatment, was my assessment, but let me know what you think about it. But also, what are the reasons in your view or the assessment in terms of, where are because clearly, if packages are not being underutilized, then there is a significant issue that we have at hand.
No, that's a really great question, and I think it strikes at the core of why I don't know, treatment abandonment seems to kind of put the burden on the patient to that they abandon it. It's more it's a question of the system having failed them for enabling them to take their complete treatment. So I would look at it differently. And I think if we assume that if you provide the costs of treatment free, we will ensure completeness of treatment, I think we're being very naive in that assumption. And there are several examples of that. What we don't understand is the fact that there are substantial hurdles and difficulties, both logistically and financially, when it comes to accessing cancer care in the country. The first is obviously financial. Let's not get away from the elephant in the room. It is financial. The cost of treatment, the cost of drugs, the cost of surgery, the cost of radiation are substantial. But schemes like the ABPMJ are able to bridge that particular gap. But what we don't pay enough attention to is, what does it take for a patient to be able to access care? So a typical patient comes to us with one or more frequently two family members who kind of give up their vocation, whatever they were earning their lives with, just to ensure that the patient, the index patient, gets the right treatment. And if you are not able to compensate for this level, either by way of ensuring that patients don't need two relatives to come with them, which is, in my view, really a 20 or 30-year program, or in the other case, how do we ensure that their loss of employment during the time it takes for the index patient to get treated is compensated? That's the other way of looking at it. And I can give a couple of examples, and I'll take the first example. I'll take the first example outside Tata Memorial, though the one that comes immediately to mind is what our own hospital has done. The Kachar Cancer Center in Silchar. Ravi Kannan, who many of you know, is, in my view, an absolute hero when it comes to ensuring that care goes down to the poorest of the poor. And the approach that he has taken in the Kachar Cancer Center, when he realized that just providing free treatment was not adequate, was to ensure employment for the family members who came with the patient. So if you look at patients being treated there, family members or relatives who accompany the patient for just to be supportive of their care have the option of getting paid employment at this hospital. So they could be gardeners, they could be cooks, they could be sanitary workers, they could be whatever, but they actually get paid for their patient being part of the hospital or being treated there, which ensures that to some extent, even if you're not completely bridging the gap, they make some money while they are accompanying patients at work at the hospital. The second example I would give you is something that initially worked at Tata Memorial, but now has expanded to other centers beyond our own hospital, which is the St. Jude's childcare centers. Yeah. So children with cancer are special, right? I mean,
Right.
they got cancer for no fault of theirs. They just got it because they got it. And the survival of children with cancer is much higher than those of adults.
Right.
And if you are not able to reduce abandonment rates in children, I think overall as a system, we've completely failed. So towards reducing treatment abandonment, which at one point in Tata Memorial was in the range of 25 to 30%. And this is just, I think, early 2000s, just 20 years back.
Right.
St. Jude's childcare centers came up with this idea that they would set up these centers in multiple parts of the country attached to cancer centers, where they would ensure that children with cancer would have accommodation, they would have free food, that parents would get employment within these centers, and the children would continue with their education. This is such a remarkable concept by itself. The fact that you're able to ensure that children getting treated for cancer, which could easily take 6 months to a year just for their completeness of treatment, don't lose 6 months or a year of employment for the parents or education for the children.
Right.
We have teachers volunteering to teach these children. It may not be the ideal school situation where they get exactly the same curriculum that they do, but it's education nevertheless. And they get involved in art, in the parents make some money working on odd jobs, they sew bags, they do carpentry, whatever it might take to make a living. So this is the overall picture that we need to look at. And if we assume that just by providing packages for cancer treatment, we have solved the problem, we are living in a fool's paradise. We need to look much beyond that. We need to look at the bigger picture, the social determinants of health, which I don't think even the high-income countries have figured out. If you look at social determinants of health in high-income countries, they look at sanitation, they look at health. They don't even look at how can a family member get employed to a point that they can sustain their own livelihoods, their family livelihoods, by working in a hospital. And hospitals are always looking for good labor, right? I mean, they want people who can be carpenters, who can be gardeners, and so on. So it's figuring this out, which to my mind is extremely important. And I don't think we can tackle this problem of adherence to treatment or compliance to treatment recommendations just by providing free drugs or free surgery or free radiation.
Right. Okay. All right. In addition to this aspect, which is obviously one of the most significant aspects, Dr. Aju or Urvi, do you want to add anything else?
Yeah, I can
sure.
Talk about the treatment utilization or the underutilization. For Kerala, from my experience working here, treatment abandonment is less of an issue. Somehow, once you start treatment, I think patients and their relatives are committed. They understand the complexity, and there is sufficient support to help them complete the treatment. Right. But treatment underutilization is an issue. And why does that happen? I work in 2 hospitals, and in both hospitals, we don't accept government insurance at all. Although ABPMJ makes it quite easy, the hospital system worries about getting reimbursed at a timely manner.
Right.
These hospitals don't have the bandwidth or the financial ability to withstand long-term debt from a big organization or a government or wherever.
Right.
So the complexity of enrollment procedures for the person and for hospitals, the delays in getting reimbursed, the administrative burden, the bureaucratic burden, all of that, the limited coverage, all of that causes treatment underutilization. That's my perspective on this.
Right. Okay. Urvi, you had anything? Yeah. Go ahead.
I have seen abandoning the treatment in case where the patients are going to get the stoma bag or something. Like I've seen patients saying it's better to die rather than leading such a life. So there we need to handle them very delicately. Another thing is I've seen so many patients dropping hormone therapy. I figured out 3 reasons. One is like it's really painful at times. and it's really long term, like 5 to 10 years. So that itself is a big thing. And one thing is like patient gets lax, that the devil is already out. We have already taken chemotherapy, radiotherapy. Now we are safe and we can do this. So I've seen so many patients stopping hormone therapy and not abandoning exactly, but there is resistance towards chemotherapy in women. So initially they say no, that we don't want to get into this, but after counseling they come around.
Right. So I think, I think that's one of the issues that we do see, that there are, I mean, you brought up hormone therapy and comes up later in our discussion on quality of life, that I think while there is great awareness and a lot of conversation around chemotherapy and the side effects and what to expect, often for some of these other treatments, patients are not aware of, the consequences. And we found this even among, as you say, the privileged patients who should have been made aware of it. They don't they get surprised by the side effects of whether it's osteoporosis, whether it's issues around sexual health and even lifestyle issues relating to breast conservation or mastectomies, etc. So that's something that I think the level of information seems to be a challenge at all levels, and the need for better communication is definitely there. Dr. Aju, I think you talked about it to some extent, and you've done this paper as well. Can you kind of talk about what is financial toxicity and, again, what are the drivers of financial toxicity?
As doctors, we are always trained in medical schools to talk about side effects of what we do for treatment. As a medical oncologist, I talk about chemotherapy, hair loss, blood counts going low. But of late, there is increasing attention on this other aspect of side effect that a person experiences, which is termed financial toxicity. Essentially, it is the financial burden that is experienced by a patient who undergoes cancer treatment. That is in sum what we call as financial toxicity. Sometimes it can go to such an extent that it threatens the stability of the household, the financial stability of a household. We increasingly understand that regardless of where you live, even in Western countries, high-income countries, this is a significant toxicity of cancer treatment.
Right. And what are the drivers for this toxicity in your view?
The key problem, as we understand, is the lack of public health spending or the governmental support, because most often there may not be insurance that covers the vast majority of our population. So if a catastrophic event happens in their life, like cancer, it takes away their financial resources and they end up with catastrophic health expenditure. That's another terminology that we use in this field, CHE, catastrophic health expenditure. But apart from the governmental or lack of government spending, some of the drivers for financial toxicity is the severity of the disease, the stage of the disease. Somebody who has stage 1 cancer, breast cancer, does not have to shell out a large amount of money versus stage 4. That is why the ABPMJ, I think, sets the limit of around 2 lakh or 5 lakh, because we know that most cancer cases can be cured within that amount. But when you get to stage 4 disease, the amount of resources that you need to fight that to live X amount of time, maybe months, maybe a year, 2 years, or whatever, becomes exorbitantly high. So stage of disease, severity of the disease, where you live, rural versus urban. Somebody may have difficulty accessing a hospital with a radiation facility, like Dr. Pramesh, getting 15 days of radiation for breast cancer, coming from 3 hours away from the hill stations of Kerala down to the city of Kochi, is challenging. The accompanying relative will have to lose 2 weeks of their income. So all of this plays a big role. Yet I am yet to see treatment abandonment as a result of that, because of the education of the disease. People understand it well here, but it is a concern. It spirals into catastrophic health expenditure. So geography, the lack of insurance, the lack of governmental spending, the age of a person, younger the person is, there is a greater risk for financial toxicity. So a lot of these are drivers of financial side effects.
Right. Dr. Pramesh, do you want to add anything to that?
No, I think Ajju is very privileged to work in the state of Kerala, which is extremely enlightened as far as their awareness about health is concerned. And I do believe that some of the best healthcare that is available in the country is available from the state of Kerala. But when you look at the hinterland, which is a completely different situation altogether, you have much higher rates of abandonment, primarily because there is lack of awareness. So, for example, you might have a perfectly curable cancer, somebody who could contribute another 30 to 40 years of productive life to society and to the family.
Correct.
Having that treatment abandoned primarily because they lack the education or the awareness to believe that this is something that is curable. And one of the biggest challenges that we have now is to break this myth that cancer is a death sentence, and the moment you get cancer, your days are numbered, and therefore, why should we invest in the treatment of this individual? And that's something that we really need to work hard to crack. States like Kerala, Tamil Nadu is another very good example of where they've been able to promote awareness to a point where abandonment rates are pretty low. But if you look at the vast majority of other parts of India, the lack of awareness kind of promotes the approach of why should we invest so much in a person's treatment when the outcome is likely to be so poor. Right. And I can think of several examples where cancer outcomes are actually superior to other diseases. So if you were to take diseases like interstitial lung disease in lung pathology, they have a worse outcome than lung cancer.
True.
Early lung cancer, not advanced lung cancer. So lumping all of this as cancer and treating them as the same is something that we need to resist. And we need to actively promote the fact that several cancers are curable. And in several others, you can add meaningful days of life to patients that with treatment than without. And that's something that we need to really promote.
So I think one of the things that keeps coming up also is on the quality of life, right? As you said, that there is, while I think there is still this concept that cancer is a death sentence, but I think we've seen that also hopefully reducing over time, and people are seeing other people go through treatment and people are talking more about it. So I think that's a good thing. The question I have again for you, Dr. Pramesh, is that, issues around rehab and even something as basic as lymphedema therapy, for instance, or support for handling stoma bags, or even access to stoma bags, other rehab support, whether it's occupational therapy, etc. How is there a plan, or is it already part of, because these are things that can't happen in a tertiary center, right? They have to kind of go into ideally primary healthcare, but if not, maybe at a district level. Is there a plan to create capability in these areas as well, or is that already happening? So you.
Again, that's a really great question. As oncologists, as people treating patients with cancer, we are fixated with seeing those survival curves go up. We are fixated with seeing those responses on CT scans and MRI scans get better. Patients don't care. They really want to look at two fundamental questions. Am I likely to live longer? Right. And is my life going to look better? Right. Overall survival and quality of life. And to me, these are the two crucial endpoints that any clinical trial should look at. And unfortunately, we've been led away by pharma into looking at surrogates, and very poor surrogates of progression-free survival, disease-free survival, and increasingly response rates as a surrogate for what actually matters to patients. So we need to really get to the core of the problem as to what does it actually mean to a patient? As an oncologist, I might get excited about a 5 centimeter tumor getting down to 3 centimeter. But if a patient is asymptomatic or a patient is symptoms haven't changed, I don't think we've really done much for the patient. So we need to get away from that particular area. The second point that I want to make is that everything comes at a cost, right? So when we think of what does it take to offer cancer treatment, increasingly we are met with exorbitant costs of treatment, which the vast majority of patients are unlikely to afford. But to me, more importantly, it builds in this factor of guilt if they are not able to offer this treatment to their family members or their loved ones. Yep. As oncologists, we need to take a hard look at ourselves and ask ourselves, is the treatment that we are suggesting to this individual patient who's likely to sell his land or get bankrupt just to have a few additional weeks or months of life is worth their while? And I do admit that this is the key area where there has to be shared decision making. But coming back to what Aju mentioned earlier, there is this huge asymmetry in knowledge when it comes to what doctors know and what patients know, or what they take away from a consultation. And here we need to go beyond just being doctoring, which is, let me look at that survival graph and look at this 2-week increase in survival and say, let me prescribe this because it's a standard of care in New York to our patients. Because if the consequence of getting a couple of additional weeks, and I'm really sorry to sound harsh at this point, if the consequence of getting 2 additional weeks or even 2 additional months of life is the fact that the rest of the family gets bankrupt, that's a question that we need to actively discuss with the family before we make the decision unilaterally. And I would strongly emphasize that this is a shared decision making. You need to actually put the facts on the board, discuss this with the family, and then make a decision as far as a treatment is concerned.
But I would like to come back. I think these are excellent points, and I think it is important to bring the point of shared decision making, because otherwise, and it is tough. I mean, I think you bring up the family's guilt as a huge issue, and we see that even in conversations around palliative care as well. But I think the other part is that somebody's been through the treatment. What is the support? How do we increase the access to rehab care? So, things like lymphedema therapists, good quality lymphedema therapists. I mean, we've had, I think when we've done the lymphedema sessions, we've had maximum attendance for those sessions, because that's such a huge gap in terms of, people. And these are, again, people with access, right? Similarly, the discussion around stoma bags. The good quality stoma bags are hugely expensive. Maybe we need to somehow convince young entrepreneurs in India to make, good quality stoma bags in India. But the point, again, even if we take something as simple as occupational therapy for head and neck cancer, or speech therapy, or lymphedema therapy, how do we make sure that this is available, is much more accessible? And, it's not like 10 lymphedema therapists across the entire country.
You're asking me?
Yeah. Yes, Dr. Pramesh.
Yeah. So I think you hit the nail on the head. So as I said earlier, these are not typically things that leadership of oncology centers take seriously. Even taking one step backwards from sophisticated areas like speech therapy, swallowing therapy, lymphedema clinics, let's get back to something as fundamental as palliative care. We admit that more than 3/4 of our patients come in advanced stages of disease, and they require palliative care at a very early stage of their illness pathway. 7 years back in the National Cancer Grid annual meeting, we raised this possibility of every NCG center having a palliative care department. And to this date, in spite of huge push championing the cause of palliative care, we've not crossed 1/3 of the NCG centers having a palliative care department. So the question of having areas like speech and swallowing, lymphedema, cosmesis is a big challenge. Having said that, we are absolutely not ready to give in to this. We run a lot of these courses within the National Cancer Grid where we emphasize that these are as important as outcomes like survival. But I think we are in for a long haul. I don't think I have a simple, easy answer to this. Unless the leadership of cancer centers across the country sign up to the fact that sometimes quality of life can actually trump survival.
Correct. Absolutely.
If you have 6 months of good life, I would value that much more than a year of an unhappy life. So as cancer center leaders, we need to accept this fact and prioritize these areas of care that so far we have neglected, because it is all considered problems of high income countries. So the moment you start speaking about how will I look after a mastectomy, you are automatically linked to, you are more worried about beauty than about more fundamental healthcare issues, which is stupid. You need to think of both at the same time, and you could do this at very low investment. Exactly. We've established speech swallowing therapies clinics, stoma clinics, all of what you mentioned at extremely low cost at our own hospital, and this provides so much value addition to patients that leadership of cancer centers really need to wake up to this fact.
Dr. you wanted to add? Yeah.
Yes, a couple of very brief points. Number one, I practice in 2 locations, and my volumes are high enough to sustain a lymphedema therapist or somebody who's a rehab specialist. So I think this is one area. The reimbursements, the money to employ somebody becomes an important factor, and this is one area I think government has to put its attention into. Government hospitals, government centers must be well equipped with rehab facilities, with all these various aspects of cancer care that you very beautifully, elegantly mentioned, the speech therapy, the lymphedema care, and all those things. The second part is, this is an area that is ripe for disruption in terms of tech-based disruption. Sometimes when I talk to breast cancer survivors or post the acute care, I tell them now focus on lymphedema therapy, and I refer them to a physical therapist. They wouldn't go because they don't see the danger that is imminent if they don't do their therapy properly. So something that I just briefly mentioned during that time is just Google. Everybody has a mobile phone now, which is smartphone. I just say, go to YouTube. Everybody is well versed with YouTube and how to click on that.
Correct.
I write in English, lymphedema, and I give it to them, lymphedema therapy and Malayalam, and they will find it. And you'll forget Malayalam. Any language is very easy. They can understand, comprehend. And a classic example is how beautifully a very rare subset of lung cancer, ALK mutation lung cancer advocacy group has worked together. They've done a tremendous job. I get patients with ALK positive lung cancer from all across Kerala. And after their initial visit, I'm just overwhelmed and flooded with screenshots, messages on conversations in their group. Hey, Dr. Aju, this is what we saw. Contact this person for this drug access.
Right.
We get compassionate use. So
Correct.
This is one area, all the rehab facilities, all the therapy is one area that is ripe for disruption. So 2 points I mentioned, one is government investment and 2 tech-based disruption.
Right. Thank you. Urvi, you want to add anything to this? I know this is an area of huge.
Yes. So Dr. Pramesh talked about caregivers' guilt. I would like to talk about patients' guilt. So once you've survived and you have survivorship issues, but then you're not able to talk it out to your family or doctors because you have an answer that, oh, you have survived cancer, you have gone through so much, these are small complaints, So when we all survivors we meet, we talk about all these things, but then there is no solution to it at times. So if we have rehab centers where we can go and get things done, it would be better.
Yeah. No, and I agree with you, Urvi. I think based on the conversation, what we find is even in the follow-ups, these questions are not asked. And that is what then shocks the survivors, that, why wasn't I told that my risk of osteoporosis goes up, my risk of lymphedema goes up. So because even in the rehab, they're not reminded by, in the follow-up, they're not reminded by doctors. So, that's a point that we really wish that people look at, as Dr. Pramesh said, beyond the size of the tumor and the CT scan, etc. But, what it takes for people to have reasonable lives. And osteoporosis is huge. It is, it causes severe deterioration in quality of life. So, so that's one part. The other thing I think which keeps coming up, and I know Dr. Pramesh, you mentioned palliative, and palliative is an area where we get maximum number of questions from people who are struggling because they don't know who to access, how to access. They don't understand the term. Nobody's brought it up to them, and they start by asking, my parent is at stage 4. Doctor says nothing much can be done. They start looking for second opinions rather than understanding that they have to look at palliative. And when they go back to their doctor to ask that question, there is even then the doctors don't respond to it. So I think that's something that we really need. We have a long way to go on this. I think in terms of, we've talked of shared decision making, we've talked of information asymmetry. But I think there's also the whole, I know you talked of caregiver guilt, you talked of patient guilt, but I think we really do need to look at the psychosocial, well-being of patients as well. And I know we are struggling in the country with resources for mental health as well. But the good thing is that I think there is a growing number of psycho-oncologists. So I think that's, but still not enough. And we need to figure out other solutions around this. The one question I had, Dr. Pramesh, was, I know we follow resource stratified cancer care guidelines. The question I have is, do we see this as a short-term or time-bound solution, or do we see this as truly being ethical? COVID has taught us, right, the challenges of inequities when you have countries which can get vaccinated 3 times over, and then there are countries who can't get the first dose access. How do we resolve this from a healthcare ethics and equity standpoint?
That's a really easy question, Aparna. Yeah. So a few facts that we need to deal with is the fact that we spend less than 1.5% of our GDP on public healthcare expenditure. We spend less than 4% of our GDP on overall healthcare expenditure. We spend more than 70% of healthcare expenditure as out-of-pocket expenses. And every year, 10% of people in India go below the poverty line because of healthcare expenditure. So these are not easy numbers to reconcile. And if you were to assume that these numbers will magically, dramatically change over years, I think we are living in a fool's paradise. We were promised a doubling of public healthcare expenditure 5 years back. It has actually reduced in the last 5 years. So we need to see how, while we continue to advocate for increased public healthcare expenditure, we try and optimize what we currently have. We could always rant and rail against the system and saying, why is the government not providing us more funding for healthcare? And while we should do it, and I'm convinced and I'm fairly certain that we will continue to do that, we also need to live with the reality that this is not happening in real time, and ensure that what money that we currently have that is allocated to healthcare is used optimally. Right. The moment you talk about that, it means that there is some form of rationing. And rationing might be a dirty word in healthcare, because I, like many others, believe that access to healthcare should be a right rather than a privilege. But we live in utopia if we think that's going to happen tomorrow. Right. So given the fact that we have this finite sum of money, our questions have to be, one, how do we increase this pot of money? And the second should be, given this money, how do we utilize it optimally? And I remember a panel discussion we had 5 or 6 years back, where we talked about the benefits of palliative therapy. I'm talking about palliative anti-cancer therapy. I'm not talking of palliative therapy, where we showed the futility of exorbitant expenditure in the last month of life. And at the end of the panel, one of the panelists was actually the person who was signing off on checks with the Karnataka version of the Ayushman Bharat. I don't remember, it was called Arogyashri or one of those, Yasashwini, one of those two.
Right.
And that person came up to me at the end of the panel and said, I didn't realize that 90% of what Karnataka was spending on cancer was actually on the last month of life. So we need to be very, very conscious about how we spend our money. And if we think that every individual patient should get the best possible care in the world, regardless of how much it costs, I don't care if it costs 10 lakhs of rupees, even if it increases survival by 3 months, we have to reconcile that to the fact that the sum of money that we have is not a bottomless pit.
Right.
And at this point, you need to take some tough decisions. How will you ensure that the person who will have a complete cure is prioritized over somebody who will have a couple of months additional survival? Don't get me wrong. I'm not for a moment trivializing the value that 2 months of additional survival has to the patient and to the family. But if the trade-off is somebody who's likely to live for 20 years more, the tough decision that you need to take is that you will prioritize the 20-year survival over the 2-month additional survival. I'm sounding extremely cruel today, but those are the facts of life. Till we have additional increased public healthcare expenditure, we are going to live with these dilemmas. And this is where resource stratified guidelines come in. And if you were to ask me to be an astrologer and look at what life is likely to be 10 years from now, I don't see this changing. I don't see this 1.5% GDP. I think the sweet spot in public healthcare expenditure is in the range of 6 to 8%. The US has gone overboard with 18%. The vast majority of high-income countries have it in the range of 10 to 11%. Thailand has it spot on at 6 to 7%. And I think this is the sweet spot that we should be looking at. Look at value-based healthcare. Look at what is the best buy for my money. While we might all be passionate because we are all cancer physicians or cancer survivors, we also need to understand that far more lives are lost by childhood diarrhea, by childhood pneumonia, and every additional rupee that you take from these diseases is going to compromise their survival. So we need to be broad-based in our thinking and look at how best government expenditure on healthcare is spent. And this is exactly where resource stratified guidelines come in. I'll stop with that.
Right. Anybody wants to add anything? No? Okay. No, I think I agree with you, Dr. Pramesh. The only point I would hopefully want to move towards is that I think we do need to find ways of having those conversations with patients and families better. And we probably will find that, there'll be many who might say, I don't want that extra 2 months so we can, cater to somebody else who really needs that 2 months, right?
Yeah. So I'll just take a minute to expand on what you said, because that's a really interesting concept. There are two extremes of the general public that we have. So there have been very good studies that have been done on what, even in countries where they don't spend personal money on healthcare, on how much of survival benefit will you take to spend X amount of money or X amount of this thing. And to my surprise, there are two extremes. There have been studies which have shown that 13% of patients would go ahead with toxic chemotherapy, even if the evidence showed that there was no benefit.
Right.
So this is where science fails us, right? The choices that patients make are most important, and Science doesn't understand that. On the other hand, we also have studies which show that for a 2-month improvement in survival, I will not go through toxic chemotherapy. So this is exactly where these individual discussions with families and patients become so important. And I think that's something where we've not done very well on in India.
Yeah. And I think, and that doesn't require that much more spent, right? So I think that's an area where we think that if we move towards, respecting the patient's preferences and talking to the patients and families, and yes, it will mean additional resources to some extent, but these are not, these can be trained, and these can be, they are not like you don't need infrastructure, you don't need, technology, etc. So it is possible to do this. And I think before I go around for final comments, and I don't think there's any other questions. I know there's a comment about how UK, even though it has good public health care, had to let go of older patients during COVID. And I think we've all seen that in COVID across Europe and US, that has been a huge challenge. But I think we do need to recognize that I think the challenges are there, but there are areas that we can work together as a community that wants to improve healthcare and access to healthcare, and look at, and from our perspective, I think we strongly believe that if we can find ways to inform patients and their caregivers and have meaningful discussions with them, I think we can do a lot more with the resources we have already. And I think somebody has questions. If you can type the questions in very quickly, we'll take the question. But before, while she's typing the question, any final comments? Urvi, do you want to give your final comments?
Yeah, we talked about information a lot, but we didn't talk about a very important thing is misleading information floating here and there.
Right.
So right source of information is very, very necessary.
Correct. And which is where, I do think that it would help if we can, create our own version of, we've tried to do on our own, but maybe we can look at ways to create an equivalent of, a thorough content which is localized in Indian languages and is easily accessible. Dr. Raju, anything that you want to close off?
I think, yes, I think patient-centered, those two words linked, is the holy grail of medicine. And, but I think there are certain specialties that have achieved it, or at least have gone much farther than we have in cancer care. And that is palliative care globally. If you take palliative care globally as a specialty, they really put patient at the center. Everything else revolves around the patient.
Right.
I dream of an era where cancer care truly becomes patient-centered. I have a long way to go from doing that in my own practice, but it's challenging. It takes time, energy. It's not easy, but we need to get there.
Yeah. We've got a question, how to avoid lobbying in insurance and finance when such value decisions come into play between quality versus longevity. Dr. Pramesh, you want to take this one?
Yeah. So if I had a rupee for every pharmaceutical company that approached us about how bad our guidelines were, I'd be a rich man. So as soon as we came out with our first set of guidelines in 2017, we just launched the guidelines. We came off the stage where we launched the guidelines formally. And the first question, the first person who met me was someone from the pharmaceutical industry, is about why our drug is not there. And that was the time we launched the guidelines. So somehow those guidelines had leaked. The pharmaceutical company knew that their drug wasn't on the guideline and on the resource stratified guideline, and they were upset. So there's huge pressure. So even when we've been engaging with the National Health Authority, one of our biggest asks from the NHA has been forwarding requests from pharmaceutical companies about why is X, Y, or Z drug not part of the resource stratified guidelines. And this is a really tough decision because currently we are relying on peer opinion more than a robust health technology assessment.
Right.
So if you had a health economics component like what NICE has in the UK,
correct,
you have very strong grounds on which you say, too bad your drug doesn't meet the HTA requirements, and therefore it's not on the resource stratified guidelines. So over the last year, we have taken several initiatives within the Cancer Grid to look at an adaptive health technology assessment program, wherein we leverage the fact that several other countries have used HTA, and using purchasing power parity, conversion rates, we are able to look at rapid or adaptive health technology assessment processes, wherein we are able to come to a conclusion about whether something is value for money or not. This is not perfect, but if you were to work for the perfect, it on an average takes 18 to 24 months to evaluate one single intervention for health technology assessment. And considering that we have hundreds, if not thousands of health technology interventions, we could wait till the cows come home before we have something on the grounds of NICE. But the approach that we took was not to allow the perfect to become the enemy of the good.
right,
Accepted adaptive or rapid HTA as a reasonable compromise to a complete full HTA, and we made significant progress. So now we are able to respond to the HTA within 4 to 6 weeks about whether a new intervention is value for money or not. So long answer to a short question, but these are challenges that we need to work with. The second part is about insurance, and the point that the whoever asked the question made,
right,
is that insurance companies need to sign up to some evidence. Currently, we are based on caps as far as healthcare reimbursement is concerned. And again, this is a lost opportunity. If you link reimbursements as the NHA has done to evidence, you will ensure that even the money that goes out of insurance companies is used wisely and in an appropriate way.
right. Thank you, Dr. Pramesh. Any final comments, Dr. Pramesh, before we wind up? I think we've gone on time.
So I think I've hogged the conversation a little bit. So I'll let Aju and Urvi give their take on it, because I think their views, especially Urvi's, is extremely important, because as Aju mentioned, we need to learn to keep the patient at the center of everything that we do, and her views on what is important is extremely important.
No, what we all talked is like, I feel it will definitely reduce the gap, if not close the gap.
Right. Dr. Raju, anything that you want to add?
The theme of this year's World Cancer Day is very good. Close the care gap.
Close the care gap, right.
Surprisingly has brought the attention, because nobody understood what it means. So people started asking me, what does exactly it means? I have politicians calling me because they have to speak in inauguration meetings about this, and asking me, what does it actually mean? So
right.
It's a good catchphrase. Hopefully people will understand. People that matter will understand and work.
Yeah, and I'm hoping that, because it uses the term care gap and not just treatment gap, it will look at the patient more holistically and, the other needs of the patient, and not just treating the tumor, right? So, but I do think that I would like to see, how we can bring together patients and patient leaders to work closely with the NCG or the other ecosystem players to create modules to train people to educate and empower other patients and families to create shared decision making models, right? Because I don't think we have that today. And to also, hopefully, we work towards a case where we acknowledge that patients and their families are really overwhelmed when they're dealing with cancer and a whole bunch of other conditions, but definitely with cancer. And we need to understand that they cannot absorb all of the information they need in that consultation that they have, right? So they need to have access to information outside of those consultations. They need to have a way to, and I, and I think we need to bring in levels of task shifting, right? Because we don't have enough healthcare professionals who can handle and as you talked of, that numbers of people with cancer will increase. So we do need to look at how we can create, bring in other people who are willing to learn and to help address some of the supportive care issues at least. So, and I think I would like to thank the panel and EHAC for partnering with us to do this session. And we do hope that we can continue to talk about this, because the Close the Care Gap is not just for this year, it's for 3 years. So let's work on the initiatives and try and create areas that we can identify, areas where we can all collaborate and move the needle as we go forward. Okay, thank you, Dr. Pramesh, thank you, Dr. Ajju, thank you, Urvi, so much.